Assalamu alaikum wa rahmatullahi wa barakatuh. We are honored to have you join us for an informed and a great webinar tonight under the umbrella of Saudi Arabian Cardiac Interventional Society and with collaboration of the Saudi Hypertension Management Society as well as the Society of Family Medicine or Saudi Society of Family and Community Medicine. Tonight, our webinar will be on resistant and uncontrolled hypertension, renal denervation therapy. We'll go through evidence, guidelines, and clinical decision making, and also the first clinical experience at Prince Sultan Cardiac Center. We have two eminent speakers, Dr. Atul Batak, who is a interventional cardiologist from Luxembourg, and we have a great speaker, Dr. Sundar Samargandi, a consultant interventional and structural cardiologist from Prince Sultan Cardiac Center. And I'm accompanied by my colleague, Prof. Abdul Hamid Hassan, who is a consultant family medicine at International Medical Center here in Jeddah. He served in the editorial board for Saudi Hypertension Guideline, SHAMS. And so we have two great talks. The first talk will be on clinical evidence, guidelines, and review and patient selection by Dr. Batak. And the second will be first clinical experience with ultrasound renal denervation by Dr. Sundar Samarqandi. And I would like to ask the audience to post their comments, their questions on the Q&A tab at the bottom of the screen, and then we can discuss them at the end of the two talks. The floor is for you, Prof. Batak, for your talk.
Thank you. Salam alaikum, Dr. Salem Asiri, Professor Abdul Hamid Hassan, and Dr. Sundar Samargandi. I'm delighted to join your society and my colleagues and friends from this part of the world. So without further ado, I will start my presentation. Can you see my slides? Can you see my slides? Yes? Good.
Yes, we can.
Thank you. So I think we, as you mentioned, Dr. Salem Asiri, living with high blood pressure, and I know we have cardiologists, but also family physician, has a lot of consequences, and we tend to forget that it remains the first cause of atrial fibrillation, of ischemic heart disease, of heart failure with preserved ejection fraction, but it's also a disease which is associated with sleep apnea syndrome, but also with chronic kidney disease or metabolic syndrome. The second very important feature is that despite multiple drugs available and also with newcomers, we are still unable to control this disease. And you can see here that among, in the US, more than 50 million patients treated for hypertension, less probably than 50 million have uncontrolled hypertension, sorry. And if you look at those who are unable to be on target despite 3 or more class drugs, you see that the number is of 5 billion. And this is a ratio you usually find in a lot of countries. 10% of non-hypertensive patients are considered as being resistant hypertensive patients. Now, this is, I would say, a public health statement, but we also know that if you are able to reduce, and a very tiny reduction, even 10 millimeters drop in systolic blood pressure is associated with a very strong positive outcome in heart cardiovascular outcome, and you know these numbers and you are familiar with these numbers. So very prevalent disease, very easy to treat, easy to diagnose, easy to follow up with the huge advantages of controlling blood pressure. But despite that, we are not able. Why? Probably because it's difficult to control these patients. And why is it difficult to control patients? Probably because despite these numbers, despite these education people and patients are still struggling with drug therapy, suffering from side effects, not convinced that they need to take a single pill for the rest of their life, especially for a silent disease. And the other thing is that probably we are not controlling mechanisms which are involved in this situation. And let me now take you into this journey because I will talk about renal denervation, but renal denervation is mainly about sympathetic modulation. And this slide here depicts the way the sympathetic nervous system is involved in the regulation of blood pressure, but also in the communication between organs. And I would like to draw your attention between these two organs, the brain and the kidney. When you stress the brain, when there is central sympathetic overactivity, this goes down to what we call renal efferent nerves through these nerves to the kidney and activate the kidney sympathetic nervous system. And this will lead to vasoconstriction, sodium retention, water retention, but also release of renin and angiotensin. So the local sympathetic nervous system in the kidney will be able to increase blood pressure through these multiple mechanisms. On the other side, if you stress the kidney by compressing the medulla, by creating ischemia, by creating hypoxia, by creating acidosis, this kidney stress will be driven by the renal afferent nerves to the brain and lead to sympathetic nervous system overactivity, not only in the brain, but also in other organs. So there is a bidirectional communication between the brain and the kidney, leading to sympathetic overactivity, leading to elevated blood pressure. And renal denervation is about cutting this communication, reducing this communication between the brain and the kidney in order to reduce sympathetic drive to the organs and thus to reduce blood pressure. So how do you do that? Well, we have devices, and you have at least three devices, three techniques. One is a radiofrequency catheter. The second one is an ultrasound catheter. The third one is a catheter using alcohol injection. But these three devices have the same aim: disrupt afferent and efferent sympathetic fibers by putting the device in the renal artery, by delivering an energy, whether radiofrequency, ultrasound, or chemical product, to destroy these nerves and reduce the sympathetic nervous system. I will just talk about the two first because they have been cleared by the FDA, by the EMEA. They have done rigorous studies and they have been mentioned in guidelines. There are two types of trials showing that renal denervation work. You have those where you take hypertensive patients, you remove all the treatments, and you just offer them renal denervation and you compare it to sham. This is to be sure that renal denervation by itself is able to reduce blood pressure and that this blood pressure reduction is not polluted by drugs. Then you have trials where you have offered renal denervation on the top of 2 or 3 drugs in uncontrolled hypertensive patients to show that renal denervation is able to optimize blood pressure control. Now, these two devices, I would say these 3 devices, have been investigated in at least 6 trials. This brings these patients to a number of 1,500 patients included in randomized sham-controlled trials. So the control arm is receiving a sham procedure. It's not I'm doing it or I'm not doing it. I'm doing something in everybody. Here, renal denervation. Here, I put a device in the renal artery. First message, no increased safety risk observed in these 1,500 patients. No dissection, no stenosis, no thrombosis, except complication at the local point of access, which is expected whenever you do a femoral approach. Now, regarding the ultrasound device, there was a very robust clinical program described here, the Radiance 2 pivotal, the Radiance hypertension solo, so off-med patient, the Radiance hypertension trio, patients who despite 3 drugs have been not controlled, but also observational studies and supporting studies, and even academic-driven studies. So what have we learned? In these 3 trials, and you can see here what type of patients were recruited: in solo and Radiance T, mild to moderate hypertension; in trio, resistant hypertension; in solo and Radiance, they were weaned off their treatment, so no drug, just renal denervation, and in trio, renal denervation was on the top of treatment. As you can see, what are the main results? Well, all these trials, and this is also very interesting, they show exactly the same effect. When you add renal denervation or when you just do renal denervation, there is a significant decrease by 8 to 9 millimeters of mercury for systolic blood pressure, more precisely for ambulatory systolic blood pressure measured during daytime. And if you extract the placebo effect, which is very tiny, 1 to 2 millimeters, the net effect is a decrease of 6 to 7 millimeters of mercury, whatever the type of patient, whether you're offering renal denervation alone or on the top of drug therapy. Second, when you follow other parameters, whether nighttime, 24-hour, but even home systolic blood pressure, you see exactly the same amplitude of effect. Patient in blue who were denervated with ultrasound had a significant decrease in blood pressure. But also diastolic blood pressure, again, a significant drop. So let's say that renal denervation drops blood pressure by 8 to 10 millimeters of mercury for systolic blood pressure, by 3 to 5 millimeters of mercury for diastolic blood pressure. You know, we hypertension specialists, we love to look these curves of ambulatory blood pressure measurement, and you see that there is a what we call an on-off effect. When you had renal denervation, you have a decrease in blood pressure, not only during day, but also during night, throughout time, throughout follow-up. Very important. The higher the level of blood pressure, the higher you're able to decrease blood pressure. And that's true in medicine. When you start high with cholesterol, the effect of the statin will be very important. When you start high with sugar, the effect of anti-diabetic drug will be strong. Same for renal denervation. The higher the baseline blood pressure, the higher the impact, the higher the effect. Also, a lot of discussion. Does it work in elderly? Does it work in patients with low EGFR, in patients with different type of ethnicity, or is there a gender issue? No, you can see here that whoever you are, whenever you get renal denervation, you get the same amplitude of benefit. Finally, a very big question was, okay, how long does it last? And we know now that at least for 36 months, you even have an amplification of effect. So you see something appearing at 2 months, it increased during 3 to 6 months, and it tends to increase even throughout follow-up for both devices, ultrasound and radiofrequency, for 1, 2, 3, but also 5, and now 10 years follow-up for the very first patients. And this, very important, you see the slide, at the end of the slide, the average number of antihypertensive medication was not changed throughout the follow-up, something around one drug for every patient. For the radiofrequency device, exactly the same result, the off-med trial, the on-med trial, and the observational trial. And you see that even the blood pressure reduction effect is exactly the same, 6.6 millimeters of decrease in office systolic blood pressure. So no big differences between these two programs in terms of clinical significance. But there was an academic trial where they compared the two devices. And this trial was very important because when you use ultrasound, you only denervate the main artery. When you use radiofrequency, you denervate the main artery, but also the branches. So the question was, is it worth doing that? And in this radiosound hypertension study where patients were randomized to receive ultrasound in the main, radiofrequency in the main, or radiofrequency in the main and the branches. What are the results? Well, you see that ultrasound is doing far a better job than radiofrequency in the branches and in the main, or radiofrequency in the main. This is statistically significant. It's a small study. It's a study which shows that there was a difference of almost 6 millimeters of mercury between these two approaches. Finally, when you pool all the data in what we call a meta-analysis, so we are expanding the number of patients, you're moving from 1,500 now to 2,300, you see that there is always a significant benefit of being denervated when you are treated with ultrasound or radiofrequency, or even when you pool the data together on any parameters of blood pressure record. Just a quick word on this last trial, the Target BP1 we published in Circulation, which was showing also a benefit, but you see that the clinical significance of this drop was not as important as those seen with radiofrequency and ultrasound yet. Now, the field is changing, and there are newcomers. The three devices I described where you will use the femoral approach, and you have now the transradial approach with the Iberis catheter, and you see again, and this is really very interesting, 6.4 millimeter of delta when you offer renal denervation through the transradial approach with the radiofrequency catheter. Exactly the same amplitude of effect, whatever the technology you use, but in this case, use something which is probably more convenient for our patient because you are using the transradial approach. And last but not least, the transradial ultrasound approach is the TIVUS catheter. The TIVUS catheter, I'm showing the data because this is exactly what you shouldn't do. You measure blood pressure before and after, and you don't do a sham control trial. You show data with these values, minus 33 millimeters of mercury. This is what we have done in the past. It's a major error. You do a sham control trial, you publish it. These results have not been published. They have not been peer reviewed. They have just been shown to the audience, to the general audience in the last PCR meeting, but they were enough to convince Boston Scientific to buy these devices for $650 million. And now there are at least 4 to 5 players in the field playing with renal denervation. Now, for the clinicians who are with us, who are the candidates for renal denervation? I think you understood the mechanism of action. You've been through the clinical trials. Now, in clinical practice, well, first you could offer renal denervation to the patient who looks like those have been described in clinical trials. The off-med patient, hypertensive patient without drugs because they feel unsafe, because they have adverse reaction, or hypertensive patients who are uncontrolled, where you want to offer renal denervation on the top. Second, you could offer this to patients who have been treated in real world. I've shown you two very big registry, the GPS and the GRS, who have recruited respectively 4 to 10,000 patients, showing exactly the same benefit in all type of patients, also in high cardiovascular risk patients. So patients from observation studies or patients who have been included in trial, but also those who have been described in guidelines. And I know that we have some distinguished faculty who have been writing guidelines in your country. So what have we decided in Europe? Renal denervation can be offered to hypertensive patients who are uncontrolled despite the use of drugs, okay? Or if drugs leads to side effects or to poor quality of life. But it can also be offered to those who have resistant hypertension. This should be shared with the patient. There should be a shared decision-making process, and this should be done in patients who have an expertise in interventional cardiology. ESH, but also other national consensus papers have followed the same path. Just to give you an example, since 2018, there have been at least 40 national consensus papers in France, in Germany, in England, in Ireland, and Vietnam, in etc., all sending the same signal. If I had to summarize all these national papers and guidelines, they all send the same signal. You could offer renal denervation to uncontrolled hypertensive patients, to resistant hypertensive patients, to patients who are intolerant to drugs, who are non-adherent to drugs, who prefer renal denervation, and some societies have even added those who have increased cardiovascular risk. These are the patients or the ideal candidate for the process. How would you offer them renal denervation? You will state that they have uncontrolled hypertension by measuring blood pressure outside the office. You will exclude secondary causes. You will evaluate the anatomy, and then you will offer them renal denervation in accordance with what we have been seeing. Now, my last couple of slides are practical slides. How can you start a program? Well, there are two ways. One, that's what I call à la carte. You know, when you go in a restaurant, you select exactly what you want. It would mean that you will select the uncontrolled, resistant, hypertensive patient who have been seen in a hypertension department where everything has been excluded. But you could go also for what I've called the buffet approach, or the approach where you could talk about renal denervation to every single hypertensive patient. You could write about renal denervation to a referral in all letters you are sending to them. You can raise awareness, you can connect, you can offer this as a solution. And this is something we've been working on. If you work à la carte, usually everything is related to a single physician who is the expert in the field, who knows the therapy, who is recognized for that. So it's easy to identify to whom should I send the patient. It's easy for referral, but it's often too late. They will send you always the more complex, complicated patients. And it's probably more scientific, but less rewarding. On the other side, if you are able to set up a team, if you are able to open the path, then it's easier to identify patients. There might be an issue with the expectation, because sometimes when you propose renal denervation to less severe patients, the blood pressure lowering effect is not as important, but it's very rewarding because you are really helping the patients. So these are the 4 criteria to develop a hypertension program. Develop a team, build hypertension focus, educate, and that's what we are doing, and also educate patients. Finally, is it cost effective? Yes. In the UK, in Germany, in Sweden, in France, it has been shown that this therapy is cost effective. Is it the end of renal denervation? No, it's just the beginning. Because as I mentioned in my introduction, renal denervation is about sympathetic modulation. In any situation where you have sympathetic overactivity, you could offer renal denervation. Heart failure, CKD, obstructive sleep apnea, but also metabolic syndrome and atrial fibrillation. And this is why we have started now to even apply renal denervation to other organs like the liver and combine renal denervation with hepatic denervation in hypertensive patients with metabolic syndrome. So you see that the future is really bright. So in conclusion, what I really wanted to share with you is that now renal denervation has reached the level of clinical use. This is based on guidelines and on trials, but also on national consensus paper. It can be used as an alternative or on the top of treatment, and the future seems to be bright. We are starting a study in atrial fibrillation. There are studies going on in metabolic syndrome and in heart failure. So I'm sure we'll have a lot of occasion to discuss about this therapy in the near future. Thank you for your attention.
Thank you so much. Thank you, Dr. Batak. I think we're going to move on for the sake of the time to next speak. Or actually, before that, maybe I can just,
Please.
say something, especially for us as a clinician, where we have both modality available, the ultrasound and radio frequency. How you pick and choose from these two modality.
Well, I think our masters always told us the same thing, whether we use drugs or devices, use the one you are comfortable with. So I would say that there are no reason to favor one or the other. I have to say that the ultrasound therapy is a faster procedure because you don't need to treat the branches, you don't need to treat the polar artery, the axonal artery, you just go in the main. Okay, so I would say that this makes the therapy shorter, but you also need to adapt the size of the balloon to the size of the artery. So sometimes you need to change. So this is maybe taking more time. So I would say that today the level of evidence for both, they have done exactly the same type of studies. They have exactly the same amplitude of reduction. So I would say do the right case with the therapy you feel comfortable with.
And then what is surprising, actually, the studies, the way how they run the studies, it's pretty much identical.
Exactly.
Off medicine, on
Exactly.
medicine, pretty much
Exactly.
identical.
Yeah.
Thank you so much. And I think we're going to move on to our next speaker, Dr. Sindhu Samarkandi, who's a dear colleague from Prince Sultan Cardiac Center, who will talk to us about first clinical experience with ultrasound renal denervation.
Thank you, Dr. Salim. So I'm going to share the slides now. Give me a minute. I think you're ready. Okay. I think you see them?
Yes.
Okay. So mine is not as much of maybe interested as Prof has presented, but I'll make it more practical for those who attended from the family medicine and from the intervention side or from general cardiology side. So just a quick like an introduction to the guidelines has been covered already. We know what we are standing. It's a class 2B for people who are approved for uncontrolled, resistant, already suffering from side effective medication or the medication intolerancy, or basically they're not being able to taking it or they don't want to take it because of a compliance issue. I'm just emphasizing from the guidelines that renal denervation per se is not like a substitute, but it's an adjunct to the therapy that we're having. So you have to take your patient as a whole and don't take it like it's just like a tunnel vision. So amplify whatever the guideline directed medical therapy for your patient based on the hypertension class and where you're standing with that patient with the other comorbids. And we know that the evolution of the RDN has started actually very long time ago with taking care of the sympathomimetic and going with improving the blood pressure. And this is like, a slide that is so nice that you look at where we're standing, where we were, and with the dip that we had between 2013 and 14. And many of the interventionists remember the simplicity problem that we had. And then we had the future coming up and more to come in the future. So let's talk about the Paradise generator or the system that we're going to talk about it. So it's a very efficient. Okay, you can see the console is basically the same. It's very automatically driven, nothing so fancy, everything just by a button. And we will show it shortly in a case. And it's very predictable in terms of the efficiency. Okay, you have different sizes ranging between 3 to 8 millimeter. With the diameter, this is the diameter, and with the depth can go up to 6 millimeter, from 1 millimeter to 6 millimeter, and then with a width of 5 millimeter. So you have like wide range of sizes, but there is some good news coming in the future, and we will talk about it shortly. So you have like a simple balloon, non-compliant in nature, and it has an atraumatic tip. An over-the-wire balloon is compatible with any wire of your choice, usually a workhorse wire of your choice. Usually my favorite is to go with a Grand Slam 0.014. And you just basically go with 2 to 3 sonication, and each session will take only 7 seconds. Most of the cases, and I will show it shortly, goes basically 2 sonication in the right, 2 syndication on the left. That's the total of 4. 4 multiplied by 7, you will find that you're under 28 seconds and you're done with the case. So the pain is very tolerable, the procedure is very short, and you have good results. So win in all aspect. We talked about the depth, we talked about the width, and we talked it's a 360 circumferential ultrasound energy, and that's what makes it beautiful. So if you can see from the view here in the short film, that is an axial view of the ultrasound lesion formation. It goes all around, it's automatic, and it can reach from 1 to 6. And then there's a hydrocooling system to prevent any thermal injury to the vessel wall. So that's a good thing also in the manufacturer engineering. And if you look at here in comparison, the ultrasound versus the radio frequency, you can see it's a 360 on the left side of your screen, whereas in the radio frequency, you might have pick some points, you have to go to the branches, and the prof already have explained that. And as I said, the seconds, if you compare the timing, within 7 seconds, you're done. That might take in the radio frequency more. So this is it. You position it, you go for ablation, and you can see the countdown on your screen from the top right. And that's actually what you see in your console. Then it starts to deflate, hydrocooling, sorry, deflate, and then you can reposition or use it in the other vessel. So here's the case. So what do we do usually? We recommend that you have an angiogram of the, descending aorta to see your both renal branches, because how many times you might get surprised and find it is a significantly tortuous or there's an actual renal artery stenosis that can explain that the patient is hypertensive. And actually, I have encountered a couple of cases that I aborted the procedure and the patient went for a stenting. One case on the table and one case was going for a TAVI workup, and we discovered it on the side. So the patient went for renal artery stenosis, stenting. Regarding the axis, it's just basically femoral axis at the time, 8 French. And then the sizing, you go into Canangio, and you can see in number 3, then you have to pick the size and you choose from 3 to 8 balloon. Most of the time, the range of the sizes go from 5 to 7 in most of the time, but it can go up and down. Most of the time, again, you can use the balloon that you use in the right, use in the left, and the left, you can use it in the right. So it's still fine. Then after you put the position your balloon, you just do an inflation and you just verify the position that you have a complete opacification, as you can see in number 4 on the left side, that there's no dye going on. Then you start the syndication like 7 seconds, and then you repeat it, avoiding this ostium of the renal artery and avoiding the branches. Most of the cases go to 2 to 3 maximum. Very rarely you find something very long that require 4 sessions. So this is a case that we have done like maybe a few months ago. And as you can see, it was like, the case started with the standard of care. You can see this is our room. We started with a safe access. Whatever you feel comfortable with, going with an ultrasound guided access, micropuncture of your choice. Most importantly, go with the safe access. And it's 8 French. And after you secure your access, you can then, this is the setup of the device. And as I said, it has a remote cartridge. It's very easy, very automatic, and you prepare. So here we're repairing this. And as we're doing the preparation, the fellows or the junior consultant are starting to do the angio and checking the renal arteries and having an estimate of what size we're going to go with. So just a quick run, because already we have did the shot, did some measurement. We're preparing the balloon just to be efficient and be quick about it. So you start with some flushing, standard care of balloon, going with your connection and with your sterile saline. And this is the catheter that as the nurses are working with the balloon, someone is working with the catheter here. So as you can see, it's shorter than we know, it's 55. And you just go with a standard 035 wire to position it and engage and wire. So that's why we skipped, we didn't show the pigtail, but that's why we already have prepared the balloon with anticipation of the size. So here the angio has been done. And then you do the standard of like, this is an 8 French. So here we're doing fluoroscopy guidance or sizing basically of what balloon we're going to take to decide. So here you will find it about 6 point something. I think 6.8 it came. Just a second, it will show you. And usually you go a bit of a upsizing with a 20-30%. So he's 5.7, so we went up with the size 6 balloon. And we continue with the case. So we introduce the wire. Usually, as I said, my go-to wire is a Grand Slam, but you can go still with cyan blue wire if you, or BMW wire, whatever, if your choice. And then once you go with that, the balloon is being ready, everyone is ready, and you hyperonize in the standard of care, just to mention that, patient should rehyperonize. You might ask, should I bring anesthesia in the room? Well, it depends on you. As I said, the whole procedure may take 28 seconds only of pain. So if you can manage it with some sedation by your own, that's great. If you need the support of anesthesia, that's not bad. It's feasible. And usually it's a short thing. It will take from then less than 10 minutes from their time. So usually when you, after you position, you confirm here, as I said, the verification of the position, and then you go for the sonication, which is going to be 7 seconds. And after you do one here, you do a final shot to make sure there is no issues or complications. And you don't withdraw it until you make sure it's completely deflated. And this is the final shots. Once you're happy, you go to the other side. Again, the same thing you do, verify the position. This is what we're saying. Then you go for sonication. And afterward, this is a still verification of the position. Happy, you go for the sonication, which is 7 seconds. In this case, you avoid the ostium of the RCA, you avoid the branches, and you have to. Once you're done, you safely remove everything, take a picture, make sure everything is good, and then you can close with the standard of care and you see suture-based wherever you feel comfortable with. So this is, we took you in our room in the cath lab. So what happened after the cath lab? So this is the initial experience in the first 3-4 months of our, since we started it from 2025. So this is the 7. Most of the patients were male. And you can see the blood pressure was really crazy, like within the 160 and up to 200. But we have received, and they, as I said, the number of sonication per artery most of the time was in 2. And the catheter has been ranging between 2 because, as I said, most of the cases we're going between 5 and 7. The blood pressure afterward in few months, we have a tremendous response, and we have a good from baseline to reduction. And I can say, but it has not been like, I didn't prepare a slide for it, but I have another 20 patients of that we had the range of blood pressure response going from 12% of baseline reduction up to 44% of blood pressure reduction. So it's a variable thing. So you do not expect like, it's a miracle number. No. And we don't stop the medication unless some patients within 1 month, they complain of dizziness and we take some of the medications off. Some of them on maybe month 3, some of them in month 4. So keep an eye on these patients and communicate with them. So it looks all sunny and shiny and flowers everywhere, but is it always the case? Well, we have emphasized a lot on the safety of the axis, but we have forgotten still we have other branches, which is the kidney branches. So this is another case that we have encountered. Looks like great, right? We have positioned the balloon. We went for the verification. We did sonication. This is the final shot. Everyone is happy, and then boom, we kind of missed. If you can see the blue arrow on the right side of the screen, there was a small puff. So that's why I like usually Grand Slam, because sometimes the regular wire don't give you the much of the support. We kind of perf the distal end of the renal artery. The patient went to the recovery. We didn't see it, unfortunately, as we're doing the case. And we went to the other side, patient to the recovery, with the assumption of discharge within a couple of hours. It's a day case in our session, in our center. But the patient started to be hypotensive, and everyone was thinking it is the femoral. But we know the femoral was ultrasound guided. We did an angio. It didn't have any like red flag. But we went back to the angio and we checked it, and that's what we found. Some hematoma around the posterior end of, as you can see from the numbers, you don't need to be an ultrasound person, but you can see some collection, a huge collection in the posterior superior area of the kidney. Fortunately, the patient survived. She didn't have a major issue. She did well with supportive conservative management. No need for surgery. It closed on its own. But the patient stayed with us for a few days afterward. So take care. Don't think everything is easy, even if you have a successful procedure. And what the fear of the intervention is always the axis. Sometimes the wire can slip, and cause another problem. So, within the final slide, experience of the power of 360 ultrasound, it maximizes the performance, as we have discussed about all the protection, the 360, the minimal time, the impact, avoiding thermal injury. And then we discussed about the staying in the main, away in the main branch itself, avoid the distal branches, avoid the ostium, and it's like, shorter ablation. That's what we talked about. So it's efficient, in other words, and it decreases the discomfort of the patient to the minimal. And the delivery lasting outcome, we showed some outcome from our side, and we're some cautious from our side only. The long-term efficacy so far in our center, we have up to less than a year, we're coming around a year. So far, very good response that we're seeing with a very good safety marker. And with that, I thank everyone and hope to work with you soon.
Thank you so much. Thank you, Dr. Sundus. Really, we enjoyed it. And I hear also you have some, data about, how many patients you did, and and the response. Maybe you didn't share it now, but like maybe in the future we'll hear about it.
Future, maybe in the SAS's meeting.
That's it. Yeah, we do, and I'm sure we're gonna have a RDN program as well during the SASIS meeting, coming September 3rd, 4th, and 5th, inshallah. So, a quick question: the hydrocolling or the cooling, um, does it act at the time where you're doing the ablation? The
So
sonic.
So once you do the sonication, it's 7 seconds. Then it stops. Then the hydrocooling will start. It's like, the quarter here, and then the deflation happens. It's like, a quick cooling, then deflation of the balloon. Then you can retract the balloon. So it's not simultaneous. So otherwise they cancel each other's.
And the sonic, the ultrasound, it says in the middle of the balloon, right?
Exactly. It's a
And it gives
360.
waves
Up to
circumferential.
in the depth, yeah, it's 360 according to the width of 5 millimeters. And depth inside, it can go up from 1 millimeter, 6 millimeter. It's kind of automatic thing. It depends because not all patients are the same size.
And that's only in the main renal artery.
Usually, what we do is in the main renal artery, we avoid the ostium and we avoid the branches. So that's why I'm saying you can just go with two. Most of the time, you go with two because the renal artery will not be that long.
And make it simple, to be honest. And as an interventional cardiologist, we like balloons, and that's what we deal with every day. So
Exactly. It's
that's
a very
great.
quick procedure, I have to be honest, because there was a question like we asked, do you have a preference like balloon RDN or radio frequency? I don't have much of an experience, to be honest with you, with the radio frequency, but balloon, I feel it is very easy, simple, quick. The most important is like, you always, when you ask other department to come, it's always to have some coordination and some delays, but you can hold the patient with some fentanyl and midaz or for 14 seconds. You can manage it. And most of the patient, they tolerated it, to be honest with you. But some of them, you need to give them something.
I think one of the main, to be honest, difference is you need to go as far as possible in by the radio frequency. So it's a little bit, it takes more time to go there, and there is a tissue contact for sure. Um,
Yes, yes.
so the
And
heat
that's
actually.
what yeah, that's why you do the verification test because you do an injection and you see complete obliteration. It means there is 100% the balloon is occluding. It means the balloon is with contact with the vessel of the wall. So,
In fact, I think it's also important to just I think elaborate on what you just said, Dr. Stamargandi, because there was a belief initially that the innervation was really important in the ostium, and that the density of the nerves was going down when you would follow the renal artery. And in fact, exactly the opposite. In fact, the density is more important when you go throughout the main, because the nerves which are arriving from a very high part of the aorta, they will go down and they will join at the end or at the mid of the main artery and then the end. So first, we have stopped treating the ostium because that's not where the nerves are. Second, we have seen that the density of the nerve is more important from the middle to the end, but then that there was also a huge density of nerves around the branches, even around the accessories, around the polar arteries, And this has been also described in cadaveric studies. These are the nerves, we call them the late arriving nerves or the very late arriving nerves. So the common belief was the nerves go down, they are very important in the osteum, and then they distribute. The real thing is that they are not very close to the osteum. They are more in the middle part of the artery and distal part. They come from very high with classical nerve, late arriving nerve, very late arriving nerve. But when you treat the main, it's enough. When you treat the main, it's enough.
Fair enough. I think we will give a few minutes for Dr. Abdul Hamid Hassan, who can maybe give us his insights on, in particularly, patient referral, patient selection, and the role of family medicine consultants in referring patients for resistant hypertension.
Thank you, Dr. Salim, and thank you for both the speakers. Very elegant presentations. Regarding referral, we received 2 years ago the American Heart Association position statement for renal denervation for uncontrolled hypertension. And they put exactly when to select the patient, what is the baseline investigations to perform, where the renal denervation is not suitable, or where we don't have enough data about some patient profile. It was very comprehensive guidelines or position statement from the American Heart Association in 2024. It is very useful, and it could be a practical guide for physician dealing with patients with hypertension. My question to the speaker, once in the ultrasound, we only denervate the main renal artery, while in the radio frequency we denervate also the branches. Is the efficacy the same? The reduction in blood pressure is the same, and the durability of the effect is the same or not?
Yes, the efficacy is the same. I've shown you some numbers, but yes, keep in mind 6.5 millimeters of decrease of systolic blood pressure when you extract the placebo effect, similar with the two devices. The durability of the effect, as I mentioned, the effect starts to appear at 2 or 3 months, then it amplifies throughout time. But at 1, 2, 3, now also 5 and 10 years, you have the maintenance of the effect. You don't need to redo renal denervation. And the maintenance of the effect is not associated with the increase in the drug dosage, because you could say, yeah, the blood pressure goes down because you are increasing the drugs, but it's not the case. So there are no real differences in terms of blood pressure reduction, durability of effect when you compare both approaches.
Thank you.
Welcome.
Thank you. So I think we have a few questions from audience, and actually great questions, and we're going to go through them. And I'm going to also ask audience if they have more questions to feel free to drop their questions and concerns, and we'll go over them. So one of the question is there any randomized control trial evidence to prove reduction in MACE?
No, there are not. There are no trial, but there are no trials with spironolactone in resistant hypertension either. But the good news is that, in fact, we are starting 2 trials in coronary patients, so stable coronary patients, where you will offer renal denervation on top of stage PCI in hypertensive patients who are uncontrolled. And it's a morbidity mortality trial. It's called the EMBRACE trial, which has already started to include patients. We are starting a second trial in patients who had an acute myocardial infarction with uncontrolled elevated blood pressure, will be offered again RDN with stage PCI. So there are 2 big trials in the coronary fields where the combination of revascularization and RDN will be explored for hard outcomes. Second, there are data, but they are not, I would say, randomized trials. They are mostly post-hoc analysis of trials showing that the patients who underwent renal denervation had less hospitalization for hypertension crisis, had less malignant hypertension, or were requiring less adaptation of drug increase to control hypertension. So it's, I would say, an indirect effect. So first, no randomized trial. Second, trials are on their way in coronary patients with uncontrolled hypertension. Third, some post-hoc data showing that the therapy, on the top of reducing blood pressure, is also able to reduce events.
Okay, but also knowing the fact that reduction in the blood pressure, that can decrease MACE, so maybe we can use it as a surrogate.
Yeah. I mean,
Um,
blood pressure is the strongest surrogate marker. And usually when you are able to reduce blood pressure, you would expect a reduction in the rate of event. There are some stories in the field of hypertension where it didn't work. For example, doxazosine, which was an alpha blocker tested in the ALL-HART trial, reduced blood pressure, but was unable to reduce the burden of the disease. So there are some strange stories, but let's say that generally, in 95% of the cases, when you reduce blood pressure, you win the match.
Well, to be honest, not long time ago, around like a couple days ago, I did one for a young patient, 49, who never saw a systolic less than 240 and a
Wow.
diastolic less than 140. Never saw
Wow.
that in many months, maybe years actually. And he was complaining of headaches, recurrent admissions, etc., on 7 to 8 antihypertensive medication, and currently he's on only 4.
Wow.
But it's around weight 140s, and I just call it a win.
Yeah.
and
on,
and
on
he
only
was
Yeah.
he
four
was really
on
happy.
only
Yeah?
on only 4 medications and control, not what,
Yes,
not
around
200.
140s or
Yes,
480s over 90s. It's it's
yes,
it's a win. In fact, he feeling a little dizzy, because you
yes.
never get used to these numbers.
Yeah.
But that's outlier. Um, Other question: is there any data to support a repeated renal artery denervation in patient who's shown recurrent high blood pressure after a prior RDN for a better control?
You want to take it, Dr. Savargadi, or you want me to answer? Is it okay?
You can. He is asking about data, but from
Okay.
technical perspective, we have been facing some cases who had a renal denervation, but radio frequency, to be honest, and RDN has ultrasound RDN has been done, and it went very well. So from the
So,
technical perspective, real life, it's been going on, and with a good response. I don't know if
but
data have
yeah,
been like a trial or something. You can follow
yeah.
up on that, Prof.
Thank you, Dr. Somar Gandhi. In fact, today there are no evidence to do a redo. Okay, but you're absolutely right. If you have been treated with radiofrequency in the old way, so treated in the ostium, a couple of points, not treated extensively, you might state that the renal denervation process was not done properly, and it's worth redoing it with another technique. Okay. But if you have done it properly, there is no reason to repeat the therapy. It's not based on guidelines, it's not based on trials, it's not based on studies. The other thing is that when you look at animal data, when you perform renal denervation, there is the appearance of a neurological granuloma, but so it's a regrowth of nerves. Okay, you see a regrowth of nerves, but these nerves are not functional. They are not linked to the artery. There are no synapses built. So there is a kind of re-innervation, but not a functional re-innervation. So up to now, there is no, I would say, evidence to support a redo of renal denervation in a patient who was not responding well if the therapy was done properly.
So I don't know, for you, Sundus, the CKD, most of the CKD patients actually excluded, I guess, from the trials, or at least in the guidelines, the cutoff GFR is above 40 to consider RDN. Is there any reason not to do it for patient with CKD
So in
or
real
advanced CKD?
I think there are some data have showing some safety signals when it comes to GFR less than 40, and Prof can correct me on that. But I've seen it. I don't have the numbers now with me, but some low GFR, it has been attempted with a successful results. Even in polycystic kidney disease, we have some case reports and dialysis patients. Now, has it been generalized? No, the data is a bit in the lower side, but it's a bit encouraging, number one. In real life, yes, we have been attempting this because one of the things that you use the therapy when you have some end of organ damage. Not to the extent of dialysis, of course, but when the patient already with the many medications, you start to have some renal impairment, you're waiting for another hit. So we usually go with it, and they have a good response. We have a couple of patients like that in my center. In other centers, they have done it off-label, just let's be clear on that, off-label in dialysis patients, and one case in polycystic kidney disease. So real life, yes, it's been going on. It's encouraging. Limited data at this stage, but I think when it's gonna come, it's gonna come. But I don't have enough data now. It's just there, but it's encouraging. Prof, can you follow in that? I don't know if you
Yeah.
have
So you're absolutely right. Today, offering renal denervation to somebody whose EGFR is below 40 is not indicated. Why? Initially, because you need to cool down the device. And to cool down the device, you need enough blood flow. So if you offer renal denervation to somebody where EGFR is too low, you're not enough cooling the device, which is not the problem with the ultrasound, but it's a problem with radiofrequency. But because radiofrequency started first, they established this rule and everybody followed the rule. Second, CKD patients are the good candidate because it's a model. It's even an experimental model of sympathetic overactivity. And it's also a model where you have difficulties controlling blood pressure, where you have problems giving appropriate drugs. Third, there are some data in patients with lowered EGFR, also in patients with dialysis. So small studies, small sample, not randomized. A very nice study from the team of Italy, from Verona, from Flavio Rebecchini, have been published. They have also changed their guidelines. And also big studies going on with Roland Schmieder. So I think in the couple of coming months, you will have data showing that renal denervation works in patients with low GFR. Last but not least, there are also data showing, as you mentioned, Dr. Samar Gandhi, that renal disease is a target organ damage, that renal denervation is also able to reduce the albumin proteinuria ratio, so albuminuria. So there is a decrease in albuminuria when you offer renal denervation. So I think that this is probably the news from the coming months, is that we will be able to offer renal denervation to patients with lower EGFR. So
Okay, well,
stay
thank you.
tuned. Stay tuned.
So the learning curve, how about the learning curve for doing renal denervation for people who is in practice?
I mean, if
Like
people who
us?
are doing intervention in regular basis are very accustomed and familiar with femoral access, I think a couple of cases would be sufficient because they're familiar with the access, familiar with the equipment, familiar with the wiring technique, and that's it. Just engage it. So it's not much. So in my opinion, if you're familiar with all of the above couple of cases, if you're still in your beginning of your intervention career, maybe 5 cases to be in the comfort zone, achieving some safety. The most important, as I said, the wire, make sure you don't have a perf like it had with me, and have a safe, comfortable femoral access. That's it, and you're good.
And then there is another comment that it sounds that the ultrasound appeared to be more easier than the radio frequency, but I think it depends on the operator and depend what you're
Comfort zone, yeah.
assigned with. So maybe I can just answer that quick. And then there was one question, and it's actually important question for people who works in private. It's a little bit tough to get approval for doing renal denervation. So he's asking, what are the key points in your service request from insurance to have an easy acceptance?
I don't have much of an experience, to be honest. I don't work in private, but maybe I don't know if other
Attack, I don't know.
I don't know, but I think I heard from my colleague that at least you have to confirm that the patient informed medication and or significant intolerance to the medication, and then it's like a back and forth. That's what I heard from my colleague, but it has to be very solid, indication with long letters. I don't know.
Sure. And also for Atul, it looks like there is a signal toward improving AFib in patient post-renal denervation. So the question here, what happened to the heart rate? Is it anything, is it also sympathetic, parasympathetic, or what is it related
Yeah,
to?
very good question, Dr. Asiri. I think so. First, there are two studies where both devices have been tested in patients who have been undergoing pulmonary vein isolation for atrial fibrillation On the top, renal denervation was done versus sham. And this patient has an implanted loop recorder, so you could follow if they had, after the PVI combined to RDN, what was the rate of paroxysmal atrial fibrillation during the follow-up. And indeed, those who had renal denervation not only had a lower blood pressure, they had obviously lower sympathetic drive to the heart, but they also had less recurrence of paroxysmal atrial fibrillation with even a lower burden of antiarrhythmic drug. So this is one thing. Second, those patients who have elevated heart rate, so above 77 beats per minute, they respond better to renal denervation than those who have lower heart rate. Third, renal denervation do not affect heart rate by itself. So you will not see a decrease in heart rate. You will also not see chronotropic incompetency. For example, if you do a stress test in a patient with renal denervation, his heart rate will go up normally during stress. So no heart rate lowering effect per se, but an antiarrhythmic effect for sure. And heart rate could be a good biomarker to identify potentially good responders to renal denervation.
Thank you so much. And I think I just noticed that Dr. Ashraf Amir actually with us, our co-moderator.
Hello.
He's the deputy
Hi,
head for the Society of Family Medicine and Community Medicine in Saudi Arabia. I'll give you 2-3 minutes to give any remarks.
Well, thank you so much, Dr. Salim, for the wonderful presentation, and I enjoyed Dr. Sundas and Dr. Atul, and it's a nice meeting to get you all together here to speak about renal denervations. And in fact, here I would like just to shed a light what is the role of the primary care physician in the context of the recommendations which and the guideline change of the American Heart Association in 2025, where renal denervation as an evidence-based adjuvant treatment for carefully selected patients with resistant uncontrolled hypertension. And in fact, many of those patients comes to our clinical practice as a primary care physician because we sit in the front line. We are first contact with patients, and we the gatekeeper of the healthcare system, so we encounter this kind. And I would like just to mention, to summarize the role of the primary care physician in this kind of clinical entity, to have the collaboration and between the primary care and the secondary care. So the role of the primary care physician is to identify the appropriate candidate. Okay, this is number one, through the criteria that has been mentioned. And then before that, we should optimize the medication management for our patient before we refer. And then we have to exclude also the pseudo-resistant and secondary causes of hypertension. And then we refer the patient to the specialist, the hypertension specialist or the cardiology. So with this, I think we have to enhance the competency of the primary care physician to allocate their position within the journey of patients through the spectrum of diagnosis, hypertension, going all the way through the different stages where we encounter with resistant hypertension, and then we take the decision of renal denervation. And as you said, Dr. Sundas, the recognition of the resistant hypertension is very important for the primary physician, because we do have many patients, they are not reaching the target of blood pressure, yet they are on 3 or 4 medications of hypertension. And these medications may be on the optimal or even reaching the maximum tolerance dose. So this is the definitions of resistant hypertension. So we have majority of it. And I think this is the time now to elevate the competency of the primary care physician to play a major role in identifying these categories of patients and then refer them right on time, because we are looking into improving the quality of life of those people and to minimize the complications that might happen because of clinical inertia or therapeutic inertia. So moving the patient from a level of primary care to secondary care, secondary level of care, right on time, in order to work for the best interest of patient and to elevate this kind of devastating complications. This is in brief what I would like to say, Dr. Salim, and I would leave
So
the
do you
floor
think,
for...
yeah, thank you so much. I mean, that's really great. Do you think we need a hypertension clinic in each hospitals? Because that's not the case nowadays. And then also, who do you think will be in charge to form a multidisciplinary team? Because I think it should be that way.
Yeah, absolutely. We are now in the era where it's not one-man show. So patients with hypertension doesn't get treated by a single physician. It's a multidisciplinary team. And we have to go through a clinical guidelines to ensure that the patient move across the board in a primary care and secondary care. We speak the same language of medicine and there is no turbulence. So the patient moves smoothly between. So that's why we are talking about the value-based healthcare, where we provide a high quality of service in a patient-centric approach, in a multidisciplinary team approach, using the clinical guideline in a compassionate integrated care, getting the clinical outcome minus the cost. So that's why, I truly agree with you, Dr. Salim, that we have to have a hypertension clinic, but I don't recommend it to be in the primary care. Why? Because managing patient with hypertension is the responsibility of every single primary care physician. It's not only a single clinic within the primary care. So everyone in the primary care should motivate themselves and upgrade their skills and competency to manage patients and to know to what level, what safe level we can manage patients. And then we have to refer the patient right in time to the specialist. So this is how we look into this. But of course, there is in certain centers of excellence of family medicine, we have many clinics. So we have obesity clinic, we have geriatric clinic, and we might have also a hypertension clinic. So it depends on the institutions and the resources that they have.
Well, thank you so much. I think we are running out of time, and I saw the enthusiasm and a lot of questions actually we didn't answer. I'm going to go through them like pretty quick. They're asking whether you continue the same drug doses or you reduce them. I think that the reason for procedure is not to reduce the medication, but rather to control. And I think all the data is shown to actually control. If you reduce those medication, that's a bonus, but it's not necessarily going to happen. And how about the antiplatelet, Prof, at all?
We do 1 month, but there are no guidelines. You could not do it. We do 1 month because we feel we are in the artery. Some colleagues don't do anything. It's up to the interventional cardiologist. What do you do, Dr. Samad?
Most of our patients, 95% are coronary cases. So already they're by default or some sort of anticoagulation. So makes it easier.
And then a kind of a question, which is, I don't think it's easy to answer, but a patient, one of the audience said, I have a 77-year-old gentleman with hypertension on amlodipine 5 milligram, which is only amlodipine, complaining of postural hypotension while on medication. When you stop the medication, the blood pressure shoot up to 160s over 70s, 80s. What do we...
So
do you do anything?
This is a typical, very interesting case. I'll give you a very easy clinical tip. When you see a patient with orthostatic hypotension, first, orthostatic hypotension is defined by a drop in systolic blood pressure by 20 millimeters of mercury and diastolic blood pressure by 10 and or could be alone within the first 3 minutes of standing. Okay, if it happens later, it's not orthostatic hypotension. So first, are we sure about the diagnosis? Second, when you measure blood pressure, you should always measure heart rate. Always. If blood pressure goes down and heart rate goes up, it means that the baroreceptors, that the regulation, that the system is working well, because that's what you expect. When blood pressure goes down, heart rate goes up. When blood pressure goes up, heart rate goes down. Then orthostatic hypotension is related to excess of treatment, hypovolemia, anemia, low salt, venous insufficiency, etc., etc. If blood pressure goes down and heart rate is stable, then you have somebody who's got dysautonomia, autonomic neuropathy, and it means that you have to manage in a totally different way orthostatic hypotension and hypertension. Okay, so measure blood pressure in the first 3 minutes, look at heart rate. If heart rate goes up, you can treat it, you can cure it. You have to find a reason why your patient is having low blood pressure. If heart rate is stable, it means you have identified somebody with autonomic dysfunction. It could be diabetic, it could be Parkinson's disease, it could be having chronic kidney disease. You need to refer them to a neurologist or to a specialist.
Thank you so much. Really appreciate it. And I just want to, I think, conclude kind of highlights, some of these webinars. We have over 1,143 registration. The active registrants is over 703, and with attendance almost around 300 hovering around 300. So that's great. We would like to thank our speakers. We would like to thank Saudi Arabian Interventional Society or Cardiac Interventional Society for taking this initiation with the help of Saudi Heart and other society, hypertension and family medicine. And we would like also to invite all of you guys to the SASIS meeting 2026 this coming September. Thank you so much, and we really appreciate it. We enjoyed our speakers.
Thank you. Thank you
Thank
for the
you.
invitation. Thank you.
Thank you for the invitation. Have a good one. Goodbye.
Bye.